So good morning and good day, and good afternoon and good evening for those who are listening to our webinar all over the globe. It is my pleasure to introduce today a new webinar about from the IOFS Society, interested in floaters and in different approaches. And this is a good occasion. And today we have a very beautiful panel of speakers doing excellent work in research in all the different aspects of the treatment options for floaters. And I think that this will be a very extremely exciting webinar today. The first speaker is from Japan. His name is Kentaro Koshima, and he will present a multi-center randomized clinical trial of YAG laser vitreolysis for Weiss ring conducted in Japan. So please, Kentaro Koshima, we are listening to your presentation.
Okay, thank you, Professor Tashon, for the kind invitation. Let me share my slides. Okay, can everyone see my slides? Yep. Okay, thank you. So today's my talk is about multi-center randomized clinical trial, YAG laser vitreolysis for Weiss ring in Japan. I am a vitreoretina surgeon working at the Kyoto Prefecture University of Medicine. So I'm a vitreoretina surgeon, but I also work in the YAG laser vitreolysis project too. So here's my conflict of interest. So Weiss ring after posterior vitreous detachment, it's very common for the floater symptom. And this may persist in some patients, reducing contact sensitivity, and sometimes have the impact on the quality of life, as you can see in these manuscripts. Okay, so our study was conducted by multi-center, and this is actually a replication study of a randomized clinical study on floater conducted by Ophthalmic consultants of Boston, Dr. Shah and his group. So this is actually a replicational study, but this was the multi-center. So our purpose was to evaluate safety and efficacy of YAG laser vitreolysis by comparing treatment group and sham laser group for symptomatic Weiss ring after posterior vitreous detachment. The study design was a multi-center. 17 facilitators participated in this study, and it was randomized, a single-blind control trial. And clinical study was approved by our ethics committee, and data management, as well as monitoring and auditing, was done by external organizers. So this was a very strict, organized, randomized clinical study. And for participants, inclusion criteria was symptom of floaters that persist for at least 6 months, and posterior detachment confirmed by fundus examination, OCT, and ultrasonic B scan. And self-assessment of visual impairment due to floaters is 4 or more on a scale of 0 to 10. So 0 was no awareness, and this most severe visual impairment was 10 for the patient. And the Weiss ring is more than 3 millimeters from the retina and at least 5 millimeters away from the lens by assessed by B scan, ultrasound. And exclusion criteria, if any of the following criteria is met, it was excluded. The maximum corrected visual acuity of the fellow eye is 0.4, which is 20/50 or less. History of treatment of retinal detachment or uveitis, or history of diabetic retinopathy, macular edema, and so on. And also a history of glaucoma. So the entry period was around 2017, year, and the patient who met inclusion criteria was randomized to 2 versus 1 to the laser group and sham group, and assessment was done after 6 months. And the treatment was only single session, only one treatment. And for the baseline, the questionnaire for the subjective symptom, VFQ-25, best corrected visual acuity, and so on was done. And all the assessment was done at 6 months. So the primary outcome was subjective changes measured by a 10-point visual disturbance score. And secondary outcome was improvement of visual disturbance compared to the baseline. And postoperative floaters symptoms, subjective and objective, as well as visual functional questionnaire done by VFQ-25. So this is written in Japanese. This is a questionnaire. So this is the primary outcome. It was done by the visual analog scale, and the patients claimed themselves they scored 0 from 10. And the secondary outcome was, it's also written in Japanese, but it was answered by the patients. And this is the VFQ-25 translated to Japanese. And this is also the secondary outcome too. So as a result, the patient who met our inclusion criteria was 54 cases, and it was randomized to 36 cases and 80 cases. But there was 3 dropouts for the laser group and 2 dropouts for the sham group, and 33 cases for the laser and 16 cases for the sham completed our trial. And the patient characteristics is shown in this slide. There was no significant difference in age. The age was around 60 years old, and mean duration of floaters was around 4 years and 3 years. And mean laser shots, it was done in a single session, was shown here. And this is, as a result, significant improvement was shown after 6 months. So for the baseline, the visual disturbance score was 6.6 in both laser group and sham group. And for the laser group, after 6 months, visual disturbance score improved to 4.1. On the other hand, in sham group, the visual disturbance score is 6.2, so no significant change. And this is the figure, the same figure. As you can see, the laser group improved significantly after 6 months. On the other hand, sham group did not improve their visual disturbance score after 6 months, and there was a significant difference at 6 months between sham group and laser group. And this is the subjective percentage of improvement. The blue bar indicates sham group, and red bar indicates laser group. As you can see, the percentage of improvement was much better in laser group. And the mean subjective percentage of improvement was 54.2% for the laser group and 18.1% for the sham group. So, and it was significantly different. And these bars show the subjective and objective floater symptoms as determined by patients and physicians. The physicians assess the floaters by the fundus imaging or the slit lamp examination. And the difference was very clear between sham group and laser group in both subjective and objective assessment. And this is a very busy slide, but this is the result of VFQ-25. For general vision, laser group did not reach the significant difference, but comparing the result from 6 months, 70.2 and 60.3, the difference was significant in sham group and laser group. And for distance activities, social functioning, and mental health and driving, laser group showed significant improvement after 6 months. And adverse events, we found no adverse events other than one case of pneumonia in sham group, which was considered not significantly associated with this treatment. So for the discussion, our study was a replication study of this study done by Dr. Shah, and this was a single center randomized clinical trial. And this slide shows the difference between our study and the prior study. So the number of patients was about the same, and the mean severity of visual disturbance score was improved to 4.1 in our study, and Dr. Shah's paper shows 3.3. And interestingly, the subjective percentage of improvement was very identical between the two studies. It was around 54%, which was very interesting. And the VFQ-25 score showed similar results. So our study showed that the patient's improvement is very similar between two studies. So the YAG laser vitriolisis shows subjective and objective improvements in floater symptoms due to wide ring after posterior vitreous detachment. And what we have learned from this study is that the laser study shows improvement, but at meantime, the improvement is very limited. So it's not around 70%, 80%, 90% improvement, but it was around 54% in both Dr. Shah's studies and our studies. So we have to know that the YAG laser vitriolisis can only resolve part of floater symptoms, not all the floater symptoms. So this is my treatment strategy. So as my treatment options, I always speak to the patients. I always give your patient their choices, and I always tell my patient that observation is the most safe way to deal with this. And if you wanna, in YAG laser vitriolisis, the invasion is not so big, but the effect is not so high. So I always tell that patient the floater symptoms will always go away. Only half of your floater symptom will go away to the patient. And if you want to get rid of all the floaters, I always talk to the patient for the vitrectomy. And also the indication has to be very strict. This is my patient who came to me for the floater treatment. As you can see here, you can see the wide ring. And I waited for 2 weeks. And after 2 weeks, as you can see here, there was a multiple retinal break. So you can always wait. You cannot rush. Wait at least a few months, even though the patient want to treat their floaters so much. And I always let my patient draw a sketch and ask them which one is the most disturbing one, and tell the patient that YAG laser vitriolisis can only resolve part of floater symptoms. So if the patient want to get rid of all these floaters, I always talk to the patient that you have an indication for vitrectomy. And always measure the distance from the retina from the lens to avoid any complications. So safety is the most important issue. This is not a sight-threatening disease. And this is the video of the laser treatment, but I think I'll just pass this slide because of the time. Okay, so indications. From my point of view, since I'm a vitreoretinal surgeon, I'm more comfortable doing a vitrectomy. So the indication from my opinion is that conditions that are difficult for vitrectomy is the indication for the YAG vitriolisis. It's around 30 to 40 years old with no lens opacity, usually high myope with long-standing floater due to wide ring after posterior vitreous detachment. and patients who understands the treatment options after fully understanding that there is no problem with observation. And do wait at least few months before considering treatment. And do let your patient draw their floater and describe which one is the most disturbing. And do explain your patients the treatment options and its benefit and risks. And don't perform laser if the patient wants all the floater to go away. Those patients are indication for vitrectomy. And don't perform or continue to laser if the vitreous opacity is too close to the retina or lens. And don't perform the laser to a patient who doesn't understand the treatment option, risk, and benefits. Thank you.
Thank you very much. I think that this is open for discussion, and we have a panel of people here that all can ask questions. I think that congratulations for your presentation. And of course, it is obvious that you have only one treatment. And often I would have said that after having done your study, do you think that some patients would benefit of a second treatment, and you would increase the 52% to a higher percentage if you were able to do a second treatment or a third treatment session, for example?
Thank you for the question. I always, for the use of the clinical practice, I always tell the patient that they need at least 2 sessions. Mm-hmm. And actually, second session would improve the improvement rate higher than 54%, but not to the not equal to vitrectomy. No. Most of the patients who received vitrectomy says 90%, more than 90% of floater is gone. But with YAG laser vitreolysis, I have no experience of patient telling me that more than 90% of floater is gone. So the most effective one is around like 70%. So, but it's a good treatment if the patient is worried about cataract progression. And if they are old, if they are 50 years or older, they may have a cataract. So, yeah, I think YAG vitreolysis is good indication for younger patients.
Yeah. No, you're right.
Kojima, yeah. In your presentation, you cited our work with contrast sensitivity and suggested that the Weiss ring degrades contrast sensitivity. That was never the case. It's a PVD, not specifically Weiss ring. So you need to understand that the statement that a Weiss ring degrades contrast sensitivity is not accurate. It's a PVD, and I'll be discussing that later. But I was curious to know why in a multi-center study of 17 centers did you have so few patients enrolled in this study? It's significantly underpowered. And my other question was, how did you account for a placebo effect? What considerations were there? And then lastly, why did you not indeed measure contrast sensitivity or do quantitative ultrasonography in an attempt to quantify the phenomenon that you're studying?
Okay, thank you for the question. For the first question, thank you for the correction, by the way, for the paper I have introduced. Thank you. And yes, it was actually a multi-center trial, but the recruitment period was relatively short. So we tried to recruit around 100 patients, but the inclusion period was very short. And actually, we have to wait it on. We had to wait 6 months, and actually, as we all experience, around 6 months, considerable amount of patients, floater symptom is much better. So, yeah, you're right. We have a low power. We try to recruit more patients, but unfortunately, waiting 6 months, most of the patients were not willing to participate in the trial. And about the placebo effect, yes, comparing with the Dr. Shah's paper, they had a placebo effect too, but our study had more placebo effect than Dr. Shah's paper. And yes, as we all experience this floater, the problem is that the objective assessment that we do for the floater using ultrasound B mode and things like that does not always correlate with patient symptom. So of course, for the floater symptom, I think placebo effect may be much higher than other diseases.
Well, in
And that's why that is one thing I am very interested in.
I understand. In 2015, we published a study correlating the VFQ-25 and the contrast sensitivity, as well as the quantitative ultrasonography. And there is indeed a correlation between those. So evaluating vitreous structure quantitatively, pre and post treatment of any type, is very useful because it does correlate with the patient's subjective experience as quantified by the National Eye Institute VFQ-25, but also measuring their contrast sensitivity. So it is correlated and something that should be done.
Okay, thank you.
Yeah, thank you very much. Other questions for the panel?
I think we have a question from Andrei Dimitriou in the chat. So
Yeah.
maybe I can read it, or Marie-José, you see
Yeah.
it?
Yeah, I see it also. Yeah. Well, his question was, in fact, what was the required minimal experience for the treating physician? How many procedures in the past? Well, not everybody. I do agree. I understand his question. I think that you need a little bit to be familiar with that treatment before you start with YAG laser, and you have, of course, also quite big differences in vice rings. Some vice rings are really very opaque, very hard, completely attached to the posterior hyaloid. Other ones are a little bit less dense, and then sometimes you can cut them better out of the posterior hyaloid. So yeah, there is a difference, and it might be interesting also to classify the different kinds of vice rings that you can because one vice ring is not the same from one patient to another, I would say. What is your opinion? Everybody was trained, I suppose. All the 17 participating centers were trained in YAG laser feature analysis.
Not really. I think that's one of the reasons our recruitment number of patients were small. Most of the doctors were not very familiar with the procedures, so maybe they had a problem recruiting patients because they are not confident for those procedures. Yeah.
I think the adaptation of the treatment is necessary. YAG laser is still a future, but I don't think in the current way it is delivered. I think there must be different. We have OCTs now, and OCT guided laser should most probably be much better than the ones that we are doing now. But okay, that's for the future. I think that no questions anymore. Then no.
Yeah, just maybe a little one. So do you know the characteristics of the laser that you used, and specifically the wavelengths of this laser?
Yeah, it's a classical ELEX is 1064 nanometers. That's a classical ELEX.
Okay, so it means that you have to co-illuminate with another laser enabled to so that to be able to see it.
Yeah, absolutely.
Okay.
But that's most of the lasers are currently the YAG lasers that are used in the clinic is 1064 nanometers, using an aiming beam as a guide. Two ones that coming together, and that you have to focus the one on both aiming beams. You have to focus them on themselves, or I don't know how you say it, and then you have you can use and hit the object. Yeah. Thank you very much, Dr. Kentaro, with this very
Thank
nice presentation, and I think very useful, certainly. And now I think it is your turn. Yes, I think so. Yes, Félix Sauvage. Félix Sauvage, a very nice researcher that I met when he was working in Ghent, and now he's back to his own country in Lille, but not the place where you were born, I think. But anyway, he will speak about the new floater treatment approaches by photoablation.
Thank you very much for the introduction, and thank you to the organizing committee to invite me for this nice webinar. So I will share my screen. Yeah. Okay. Pointer. Do you see my screen? Yeah. Okay.
Yes, everything is okay.
Okay. So today I will introduce to you the works that I have done as a postdoctoral research scientist in Ghent, Belgium, with Professor Stéphane De Smet, and in collaboration with you, Marie-José, and Jerry Sibak. So actually, I am in Lille now, but I will be back to Belgium. So I'll give you more details in private. So basically, we have investigated new photo treatment approaches by photoablation, so at a preclinical stage. So we've seen in the presentation before that there is clinical studies, and here we are really at the preclinical stage. So of course, you all know here the source and the cause, let's say, of vitreous opacities, which are actually structural abnormalities which are associated with vitreous liquefaction. So we know that in the vitreous, we have a thin collagen network, and that with aging, there is a progressive liquefaction of the vitreous, which actually will lead to the collapse of this collagen network, forming aggregates that can be seen by some patients and can tremendously impact vision and quality of life. So we have very nice pictures here to illustrate that, so credit to Jerry Sibak. So postmortem pictures in patients at different stages of life, and you can see that there is scattering, more and more scattering elements that can be observed in the vitreous with time. So you can see here, for instance, in a patient around 50 years old, and here in an old patient. So as you can see, of course, the clinical let's say symptoms of floaters are silhouettes and dark spots that are in the field of vision, and which scatter lights and create shadows on the retina. So far, and I will not insist on this slide, the current therapies are the following. So first, we have the patient reassurance and how to cope and live with the symptoms most of the time. As we've seen before, there is the YAG laser treatments and, of course, the vitrectomy, which consists in replacing the vitreous, removing the vitreous, and then removing the opacities and replace the vitreous. So in our laboratory, we have an interest in nanotechnology and photonics, which is actually the combination of using light and light-responsive or light-absorbing nanoparticles. And so this all started with the work of Professor Breitmans to deliver compounds into cells. And we try to adapt this physical phenomenon to ophthalmology, and more particularly for the treatment of eye floaters. So basically, when you illuminate a gold nanoparticle, so a plasmonic nanoparticle, or even a light-absorbing nanoparticle, this particle will absorb light and heat up in an ultra-fast fashion. And this increase of temperature, very locally and transient, will actually lead to the evaporation of the surrounding water, which will create a vapor nanobubble emerging from the surface of this nanoparticle. And as every bubble, and this follows the Laplace law, this bubble will expand and collapse, which will generate actually mechanical forces. And so the rationale behind the use of those mechanical forces was like, are they sufficient to destroy opacities and vitreous floaters in the eye of patients? So we have designed gold nanoparticles that could be injected in the vitreous of patients, and we have coated those nanoparticles with hyaluronic acids to provide them with high mobility after injection and to increase the probability to reach the floater after injection. And we result that actually when we illuminate those particles that are bound to the opacities, that we could locally generate those vapor nanobubbles to mechanically destroy the opacities. So, of course, we were the only ones to try to find an in vitro model for floaters. So we decided first to synthesize and produce type 1 collagen fibers as model fibers. And so the first observation that we had is that we could actually, when we mix those fibers with gold nanoparticles, detect these particles as bright spots here on the surface of these fibers, meaning that actually those particles could bind and aggregate onto those fibers. When we illuminate locally those fibers bound with gold nanoparticles, we could see the emergence of small bright spots at the surface, indicating that we could generate those tiny bubbles at the surface of those fibers. Playing around with the number of pulses and the laser energy and the concentration of particles, we were able to destroy significantly those fibers, as you can see here. So this has been done in the tube, and the most optimal fluence to reach this effect was 4.5 joule per centimeter square. Then we have discussed with ophthalmologists, and one of the huge problem, so to say, is that there is no type 1 collagen in the vitreous. So that's too bad regarding the previous experiments. So in collaboration with the VMR Institute and with Dr. Sebag, we received real opacities from patients, and we repeated the process. So we mixed in the tube those human opacities with gold nanoparticles, and we applied the laser to see to which extent and what were the characteristics to destroy those opacities. So I'll try to play the video. It's always a problem. So I have to remove the pointer. Yeah, sorry, just yeah. So here's of the type 1 collagen fibers mixed with gold nanoparticles where the laser is applied. And as you can see, we could easily remove the opacities. On the right side, this is a human opacity, so provided by the VMR Institute, and we could as well really destroy these opacities. What is interesting here is that you can see these little tiny bubbles at the surface of the opacity. So which shows again that the rationale behind was the hypothesis was actually the good one for the mechanical destruction of the opacities. So then we tried to complexify a little bit the study, and so we decided to move towards in vivo studies in rabbits. So we have then decided to inject the type 1 collagen fiber intravitreally in rabbits, as such that they were located very close to the retina, which is actually a worst case scenario in the clinic. So we were able to actually bring those opacities, let's say between 500 half millimeter from the retina, as you can see here. So this has been done in collaboration with Professor Yanis Paulus from the Kellogg Eye Center in Michigan. So the first observation after injection is that when we after having injected the fibers, when we injected the gold nanoparticles, is that we could clearly see the gold nanoparticles in fundus imaging. For a simple reason is that they are red and they give a red coloration, and that they were overlaid with the location of the fiber that has been injected, and we could see that by OCT imaging and photoacoustic imaging. When we applied the laser in the area where the fibers were located, here in the dotted square, we could clearly destroy the population of fibers here after only 7 pulses at 4.5 joule per centimeter square, which is very, very low energy, and which will allow us, this is our hypothesis, to get closer to the retina compared to the YAG laser. Of course, we all know that using gold nanoparticles in the clinic could be a problem for a simple reason is that gold nanoparticles, though they are biocompatible, they are not biodegradable, which can be a problem and specifically for the residence of those particles in the vitreous. So we decided to try to which extent we could investigate clinically approved dyes like indocyanine green, which is used to stain the inner limiting membrane during vitreoretinal surgery or to image the blood retinal vessels. And so since ICG is absorbing light, we wanted to see to which extent it was possible to create those tiny bubbles at the surface of floaters to destroy them. So we repeated the full sequence, the full experimental sequence. So we actually first work with the collagen fibers in the tube, the human opacities provided by Dr. Sibak, and similar as for the gold nanoparticles, we were able to destroy those fibers and those opacities in the tube. Then we repeated the experiments in vivo, and we were quite surprised that using 1.25 milligram per milliliter concentration of ICG, which is actually lower than the concentration that is used for ELM staining, we were able to actually bind the opacities after injection. So here, this is a three-dimensional photoacoustic imaging. So in orange here, you see the location of the fibers. In green at 800 nanometer, this is the injected indocyanine green in the vitreous. And when we make an overlay, we can see that ICG is actually at the spot of the collagen fiber. So regarding the efficacy in vivo, we actually could destroy the opacities. So the laser itself, without any photosensitizer, without ICG, didn't do anything to the opacities. Then when we applied the laser at concentrations of 0.6, 25 and 1.25, and when we scanned the area where the laser, where the fibers were located, we could destroy those opacities. I will not go into detail, but one of the reviewer during the publication of this study asked us to prove that bubbles were formed in the vitreous, so we could measure the cavitation phenomena after injection in the vitreous, which is due to the presence of vapor nanobubbles. So this is my last slide. We then decided to see to which extent we were toxic or not, or safe with this approach. And so we performed ERGs, and we couldn't see any differences in rabbits treated with ICG, gold nanoparticles, and non-treated rabbits, which is rather promising in terms of conservation of the functionality of the retina. And then we performed histology to check for actually the morphological impacts, if any, of our approach. And again, we didn't see any clear changes in the morphology of the treated retinas, and as well when we performed a tunnel assay to assess for apoptosis or cell death in general in the retina, we didn't see any changes, which supposes actually that our approach in rabbits after 30 days was safe. So to conclude, so we just proved that laser-induced vapor nanobubbles can destroy vitreous opacities in vitro on type 1 fibers, ex vivo on human opacities, and in vivo in rabbits. And what is very interesting is that only a few shots are needed, less than 20, at a very low laser fluence. Vital dyes that are used in ophthalmology are efficient for the destruction of opacities. So we used ICG, but for instance, trypan blue or brilliant blue could be used as well. They are already approved, and no retinal toxicity was observed in rabbits, both with ICG and gold nanoparticles. Thank you for your attention.
Thank you. Thank you very much, Felix. This is exciting research indeed. And I think that, okay, there is maybe that we could think about, and that I would like to have your advice, we could think about to link the laser treatment, the laser wavelength that is much more advantageous than the YAG laser, classical YAG laser of 1064 nanometers, to couple it with OCT visualization and of the eyeball. But then you need, of course, to have the full globe that can be visioned. Do you think that would be an option?
I think it's already investigated by German researchers to couple femtosecond lasers, femtosecond laser, so not the YAG laser with OCT, but indeed, as you said, if we are able to couple OCT imaging with the currently available YAG laser, this could be a huge step forward for diagnosis and for treatment as well. Yeah. And indeed, so the wavelength that we use actually here with the gold nanoparticles is 532, which is not the wavelength of the clinically available YAG laser, but and the same for ICG. We have wavelengths of 800. So we will need as well to adapt the wavelength and to tune the laser to be able to be efficient on this matter. But of course, imaging is very important. And as we could see with Professor Paulus, actually we can do photoacoustic imaging. And with photoacoustic imaging at a wavelength of 532, we see the floater, and at a wavelength of 800, we see the ICG. And then by this, we can really combine, the properties of ICG and the visualization of the floater for a more efficient treatment. So we didn't think about it, but photoacoustic imaging could be very, very useful as well for this.
Well, yeah. The reason that it worked in the rabbit is because the vitreous body in the rabbit is very small. And the problem in humans is that OCT does not image enough of the vitreous body to be clinically useful. So there has to be significant improvements in the imaging technology before what you're discussing can be achieved.
Yeah, but then of course you cannot use the traditional ones. You have to use the en face devices, and they are most probably much more promising for the future. And then still then we will have to see whether we can evaluate and objectify very carefully and very accurately the laser floaters. And then of course we have also the degree of liquefaction of the floater or the vitreous might also be necessary to measure, and be interesting to have an idea how highly liquefied the vitreous is of the patient. Would that play a role in the lasers that you use, Felix? Liquefaction, the degree of liquefaction of the medium?
I think so. I mean, even though I assume that the refractive index would be likely the same between the liquefied areas and the gel areas. That's of course, because otherwise we all have liquefied vitreous, and with time it's not like we see pockets of liquids in our vision. But so I think it's important as well but I guess more for the movement of the particle of the opacities. When they are located in a liquefied area, they can move, and they might be more difficult to target as well. So regarding the assessment of the liquefied parts, I guess there's been one paper that has been published in this regard with ultrasounds, where they measure the different relaxations in the gel vitreous or in the liquefied vitreous to be able to image via ultrasounds and to map the liquefied areas. We could use as well some dyes that are viscosity dependent. But again, this could be quite hard to put into the clinic because these are complex dyes, and we will have to be sure they are safe for the patients. So we have to go through the full process of let's say agreements and FDA approval and so
Concerning dyes, Felix, you said ICG was used. And you're sure that other ones would be effective? Because we have reservations about using ICG in the human retina.
Yep. Yeah, so we are currently investigating that in Ghent. We first tried with ICG. We have published that in Nature and Nanotechnology last year. But of course, this was just to exemplify, let's say, the use of ocular dyes for this purpose. But indeed, trypan blue can do the job. We have evidence on that. But the problem is that trypan blue, the wavelength is 561, and I'm not sure it's very nice to use this type of this wavelength in the eye compared to infrared, near infrared to be more precise, with ICG, because there is less absorption by the biomolecules of the retina. Brilliant blue could be used as well, so we are really investigating that. Indeed, we have this always this toxicity concerns that arise for the use of ICG, because of course there is ICG basically is phototoxic. So what is happening there in terms of let's say degradation products or radical oxygen species is still not a mystery, but it's not still not elucidated, I must say. So this is questions that we need to answer to move forward with DICE, indeed.
Felix, I think it's overstated to call ICG phototoxic. It's photoreactive. And I'd like to go on record as saying that the whole issue of ICG toxicity is overblown. I've been using ICG for many, many years without any problems whatsoever. I do dilute it doubly to mitigate against any untoward effects. But when used judiciously and carefully, it's extraordinarily useful in dissecting membranes and the ILM. So its use in this context should not be tainted by the perception that there is phototoxicity. It's photoreactive.
Yeah. Indeed, I think there are huge debates on the use of ICG among the ophthalmologists. So, as a non-ophthalmologist, I have to choose my side, let's say. But indeed, so it's not that we see clear toxicity in rabbits with ICG either injected alone or in combination with laser. So, we are confident so far. Yes.
Okay. Thank you. Some more questions? No, then I don't know whether it would be, I leave it to you, Jerry, or to you, Christophe. Maybe that it makes more sense that now Jerry presents his vitrectomy presentation, and then we go further with Christophe. Is that fine for you, Christophe?
All fine for me.
For you? Okay, and
No
for
worries.
you, Jerry, is that okay for you?
Sure, that's fine.
Okay, thank you.
So let me see how to share screen. Okay, here. Is this visible to all?
Yeah. Yeah.
Can you see my screen?
Perfect.
Very good. Well, thank you for inviting me to speak on curing vision-degrading myodysopsia. That's the term that we employ to refer to clinically significant cases of vitreous floaters. And it's not an arbitrary designation, as you'll hear in this presentation. There are very strict criteria that are based upon objective quantitative measures that are employed to make the diagnosis of vision-degrading myodysopsia. But first, we need to understand its origins. And to do so, we have to begin with biochemistry. Vitreous is a remarkable structure that's 98% water, and the 2% structural macromolecules are primarily hyaluronan, which renders viscoelasticity, and collagen, which provides the structural framework. There's an intricate interaction between collagen and hyaluronan that underlies the transparency, but also the loss of transparency that occurs with aging, as well as with various diseases. Fibrous liquefaction is the fundamental pathophysiology of loss of transparency within the vitreous body, most commonly related to aging, as Felix has described. In children, hyaluronan molecules separate the collagen fibrils so as to minimize light scattering and maximize photon transmission to the retina, where vision can begin. By middle age, there's rearrangement with displacement of the hyaluronan molecules that are very hydrophilic, so they draw water with them, creating liquid vitreous. But the collagen that's left behind cross-links and becomes aggregated into fibrous structures that course from the vitreous space to the posterior vitreous cortex. By old age, there's further aggregation of the collagen, and it's associated with pockets of liquefied vitreous, such as you see here in the bottom panel. This entire process is accelerated in myopic eyes, so that 10 to 15 years early in the life of a myope, we have fibrous liquefaction, and that leads to changes that induce floaters. There's also a series of changes that occur at the vitreoretinal interface. We know that there's very strong adhesion between vitreous and retina in youth, and this weakens with aging. but we don't really understand the underlying mechanisms. There is thickening of the basement membrane, basically the ILM, which may underlie this weakened vitreoretinal adhesion. But the combination of fibrous liquefaction and dehiscence at the vitreoretinal interface results in a posterior vitreous detachment. And these two processes need to occur in tandem in order for the PVD to be innocuous. But even an innocuous PVD can induce the visual phenomenon of floaters. And I know a lot of people describe or use the word floaters to describe things in the vitreous body. I like to be pure about it and emphasize that floaters are a visual phenomenon induced by opacities in the vitreous body. And it appears that the posterior vitreous cortex is very damaging to vision, induces a lot of the floaters that patients see after a PVD. And I always thought it was only because of the dense collagen matrix that is shown by scanning electron microscopy in the lower right. But I've recently started to theorize that once the vitreous separates away from the retina, the posterior vitreous cortex is forced into a smaller surface area than it normally occupies. And consequently, it's thrown into folds. And I believe these folds induce multiple scattering and create the disturbance to photon transmission that patients perceive as floaters. The Weiss ring is also another observation that patients can even describe. And here you can see by ultrasonography in the upper left and in the upper right, the appearance of the Weiss ring, and in the center, advanced fibrous liquefaction in an 88-year-old individual. But the fundamental question is whether all of these are just a nuisance or whether it's truly a disease. If you ask the patients, there's no question that it's a disease. They equate the negative impact of floaters on their lives to age-related macular degeneration and greater than glaucoma and diabetic retinopathy. Indeed, it's so bothersome to them that they'd be willing to accept a 7% risk of blindness and exchange 1 year of every decade of remaining life just to be rid of their vitreous floaters. But many doctors consider floaters just a nuisance, and I've often wondered, why is that? I believe it's because of the absence of objective clinical indices of vitreous structure and visual function, abnormalities that we could use to define vitreous floaters as a disease. And the absence of these hampers acceptance by many doctors as clinically significant. So we've dedicated the last 10 years or so of our R&D to define vision-degrading myodysopsia in terms of objective quantitative indices that can help both in clinical research, but also in clinical care. We began by measuring contrast sensitivity using the Freiburg acuity contrast test that was developed by Mache-Bach at the University of Freiburg in Germany. And the product of this is a Weber index defined as you see at the top. The concept is that the lower the Weber index, the better the contrast sensitivity. And we've shown reproducibility in a couple of studies around 90%. In a prospective study, we found that PVD degrades contrast sensitivity by 54%, perhaps by the mechanisms that I alluded to earlier. A larger retrospective study of 139 patients with significantly bothersome floaters found that contrast sensitivity was 4.6% Weber. Recall, the higher the Weber index, the worse the contrast sensitivity. 70 controls who did not have floaters had an average contrast sensitivity of 2.4% Weber. And this represented a 91% worsening in the patients who had vision-degrading myodysopsia. The other objective quantitative index that we employ is quantitative ultrasonography. We've developed this with a group in New York, employing the Quantel ultrasound technology. On this graph, you can see contrast sensitivity below on the x-axis, and on the y-axis, you can see in arbitrary units the quantitative ultrasound index. And what you find is that the worse the density, the greater the density of the vitreous, meaning higher numbers on the y-axis, the worse the contrast sensitivity on the x-axis, because the Weber index increased, and that means worse contrast sensitivity. So the more dense the vitreous, the worse the contrast sensitivity. PVD is indeed the leading cause of vision-degrading myodysopsia, and as I mentioned earlier, in a small preliminary study of patients who we were able to see before they had a PVD and measure their contrast sensitivity, we found that it was relatively normal, but after their PVD, it degraded by 52.5%. In a subsequent study, we found that after the vitreous detaches, it further opacifies, and you can see that there's a further increase by quantitative ultrasound with increasing age. The blue dots represent patients with PVD. The red dots represent eyes that do not have a PVD. On the x-axis, you can see increasing age, and with increasing age, there is increasing density of the vitreous by quantitative ultrasound. But that's also correlated with worsening of contrast sensitivity, because here, once again, after the vitreous detached, there is worse contrast sensitivity with increasing age, which is on the x-axis, and contrast sensitivity on the y-axis. Again, the higher the Weber index, the worse the contrast sensitivity. So after a PVD, you have degradation in contrast sensitivity, but there's continued increased density of the vitreous that also worsens contrast sensitivity with age. The second leading cause of vision-degrading myodysopsia is myopic vitreopathy. And in a study which we published in the AJO last year, we correlated the degree of axial length with vitreous echodensity. In the graph in the center, you can see on the x-axis increasing axial length, and on the y-axis increasing vitreous echodensity. So the longer the eye, the more myopic the individual, the more dense the vitreous, and in turn, the worse the contrast sensitivity. In fact, we found that the worst patients of all were those who had myopic vitreopathy and the PVD, a phenomenon which occurs around 15 years earlier in the lives of myopic patients. In fact, I think a study done in Japan showed that with every diopter of myopia, there is a decrease of 0.9 years in the average onset of a PVD. Yonemoto did that study, I believe. So having defined vision-degrading myodysopsia in objective quantitative indices, we are able to open the door to treatment. We never treat anybody without this type of workup, without really understanding the vitreous, not just clinically, but using quantitative ultrasound as well as measuring their contrast sensitivity. And so we have available to us YAG laser vitreolysis as well as vitrectomy. In about 20 years ago, Delaney and colleagues compared YAG laser to vitrectomy and found that 62% of patients had no effect, 38% had moderate improvement, but 93% were better after vitrectomy. A survey of ophthalmology article reviewed the literature as of 2016 and found no published evidence of YAG laser efficacy. A Cochrane database study, first authored by Kokovac in Australia, found that there were no clinical studies proving efficacy of YAG laser. And then the study that was cited earlier by Shaw and Heyer randomized patients with Weiss ring to YAG laser or sham treatments. And although they found statistically significant results, these were not clinically significant because there was only about 50% improvement in only about half the patients. And a letter to the editor pointed out that the reason for this is YAG laser is the wrong energy. It is not a photoablator, it is a photodisruptor. We did a study in our patients who have undergone YAG laser treatment elsewhere and compared them to a group of patients who did not have YAG laser treatment. And we found that there was no better contrast sensitivity in the group that had YAG laser, and that the vitreous density was the same as in the group that did not have YAG laser treatment. But there were weaknesses to this study. It was retrospective. We did not have any pre-laser evaluations, and there was no uniformity in treatment because these were multiple referring doctors who had done these treatments. And so that introduced variability that weakened the study. It's important to point out that within this study, which we published in Ophthalmology in 2019, there was a subgroup of happy individuals, people who did not want to undergo vitrectomy because they felt that they benefited from the YAG laser treatment. And indeed, in this small subgroup of individuals, the density of their vitreous was less and their contrast sensitivity was better. But we never measured them before the YAG laser treatment, so we don't really know. And the conclusion of this study was that we need a prospective study that employs objective quantitative outcome measures that are done before as well as after laser treatment to determine A, does it work at all, and B, for whom does it work? Because as in anything else, case selection is critical. And all of this information is what led to NICE, the National Center for Health Excellence in the UK, to recently declare that the evidence on the safety and efficacy of YAG laser is inadequate in quality and in quantity, and that this should only be used in the context of research and should only be done by retinal specialists. Given all of that, our treatment of choice is limited vitrectomy, which is sutureless 25-gauge vitrectomy, during which no surgical PVD is induced if the patient does not have a PVD. And if the patient is phakic, we preserve 3 to 4 millimeters of vitreous behind the lens because it contains the framework, the substrate, and the antioxidants to mitigate against the reactive oxygen species that would promote cataract formation. In a preliminary experience of only 8 patients without PVD who had similar contrast sensitivity in each eye, the PVD lowered the contrast by 54%, yet a limited vitrectomy restored contrast sensitivity 1 month post-op and was sustained for 1 year. A second preliminary study of 76 cases that had a mean follow-up of 17 months found that contrast sensitivity was normalized at 1 and 3 months post-op. In that study, we saw a 23.5% incidence of cataract formation requiring cataract surgery at an average of 15 months, and that led to another study where we compared head-to-head extensive vitrectomy as performed at the University of Amsterdam with limited vitrectomy as I've defined it. And at a 2-year follow-up point, the incidence of cataract surgery in limited vitrectomy was 35%, while those that underwent extensive vitrectomy with the induction of a PVD had cataract surgery in 87%. Also, the mean time from vitrectomy to cataract surgery was 7 months in the extensive group and 13 months in the limited vitrectomy group. The largest study was in 195 eyes of 146 patients who underwent limited vitrectomy for vision-degrading myodysopsia. The demographics are shown in the upper part of this slide. The etiology of vitreous floaters is shown in the lower part. Half of the patients had a PVD as their cause of floaters. The mean age of this group was 63. 16% had myopic vitreopathy. Their mean age was 41. And 28% had both myopic vitreopathy and PVD. A very small subgroup of individuals is asteroid hyalosis. On the right in the lower corner, you can see the outcome measures that we employed for determining efficacy of this approach. VFQ showed that satisfaction increased. General vision was better by 30%. Roll difficulties were better by 32%. Quantitative ultrasound showed that vitreous structures greater than 0.07 millimeters in diameter decreased by 94%. Visual acuity improved from 2030 to 2025. That was statistically significant, but not clinically significant. What was clinically significant was the improvement in contrast sensitivity. And in this graph, you can see a comparison of 70 controls in the far left who had an average contrast sensitivity of 2.4% Weber. Recall, the higher the Weber number, the worse the contrast sensitivity. Therefore, the 139 individuals complaining of floaters had an average degradation of 91.3% in their contrast sensitivity. Within 1 week of limited vitrectomy, every single case had normal contrast sensitivity. And as you can see, this was sustained for months and years thereafter. In terms of complications, there were very, very few. The mean follow-up in this cohort was 32 months. 50 of these individuals were followed for more than 4 years, and almost 24 were followed for more than 5 years. There were no cases of endophthalmitis and no IOP problems, either hypotony or glaucoma. Vitreous hemorrhage occurred in 2 cases, but cleared spontaneously and did not require any intervention. There was 1 case of cystoid macular edema out of 195. Retinal breaks occurred in 3 cases, and retinal detachments occurred in 3 cases. All of these were identified and treated successfully. Symptomatic PVD post-op occurred in this study in just 4 patients, but we're currently doing a follow-up study, and I have information for you should you desire to know more during the question and answer of this presentation. There were retinal vessel occlusions in 5 individuals, and cataract surgery was only required in 16.9% of the phakic individuals. The mean age of the people who required cataract surgery was 64. No one under the age of 53 has ever required cataract surgery following limited vitrectomy. So this is very clinically effective, but it's also cost effective. A study that we did in collaboration with Gary Brown in Philadelphia found that the cost-utility ratio of limited vitrectomy for vision-degrading myodysopsia was superior to cataract surgery, amblyopia therapy, and retinal detachment repair. We published this in the AJO in 2019. We also did a recent study looking at patients with multifocal IOLs. Given the importance of measuring contrast sensitivity, and given that we know that multifocal IOLs can degrade contrast sensitivity, we asked the question whether patients with multifocal IOLs would respond in a similar way to a limited vitrectomy. So we did a study of 180 patients. 55 had multifocal IOLs, 60 had monofocal IOLs, and 65 were phakic. Preoperatively, contrast sensitivity in the multifocal IOL patients was 25% worse than in the monofocal IOL eyes, and that's consistent with past studies. And this was in spite of the fact that there was no difference in the echo density in the different lens cohorts. So we concluded that the greater contrast sensitivity degradation in the multifocal IOL eyes was due to the lens itself. So it's an additive effect. Both the vitreous and the multifocal IOL degraded the contrast sensitivity. Postoperatively, vitreous density decreased by 71, 76, and 86% of these patients, and this was statistically significant. But most importantly, contrast sensitivity improved in all lens groups. And here you can see on the left, the multifocal IOL contrast sensitivity, the average contrast sensitivity, which was 5.04% Weber pre-op, dropped to 3.16%. That 37% improvement was very much appreciated by these individuals, and it was statistically significant. It's true that the monofocal IOLs and the phakic eyes had greater improvement because the multifocal IOLs still had an impact on their contrast sensitivity. But the patients were very happy and had much better vision, at least as measured by contrast sensitivity. So in conclusion, vitreous floaters induce a significant impact on the quality of life. And we believe that this is primarily by reducing contrast sensitivity function, but there are other aspects to vision that we don't have the time to get into concerning driving and reading and the saccadic eye movements that displace the vitreous body, etc. The quantitative index that we've developed, specifically measuring contrast sensitivity and performing quantitative ultrasonography, as well as VFQ analysis, can be used to define vision-degrading myodysopsia. And these clinical metrics are very important for case selection in clinical care, but also as outcome measures of all forms of therapy, vitrectomy, YAG laser, pharmacologic vitreolysis, and other things to come. But today, Limited vitrectomy is clinically successful and cost-effective. It improves vision and well-being in all patients, including unhappy multifocal IOL patients. So for those of you who have such patients who are unhappy with their multifocal IOLs, I would consider ultrasonography of the vitreous, measuring their contrast sensitivity, and discussing with them the possibility that happiness can occur following limited vitrectomy. Thank you very much for your attention and for this invitation.
Thank you very much, Jerry. This is, I completely agree with you regarding the multifocal intraocular lenses. They are reducing visual acuity. Maybe that with the EDOF lenses, it will be a little bit less, but anyway, you cannot reduce. Don't forget that by operating cataract, we increase contrast sensitivity, and we have the fluence of light that goes in through that enter the eye is much more important than if you have your lens still in place. So I think that compensates a little bit. But anyway, multifocal intraocular lenses, certainly the first generation of multifocal intraocular lenses, they do decrease dramatically contrast sensitivity. I do agree with you that, of course, by taking away surgically the floaters, that of course the patients will be much more happy than by performing a YAG laser vitreolysis. On the other hand, I think that we do have also quite a lot of patients that do not want to take the risk of the complications, even if those complications are relatively low. And that is low, but not zero. If you add all the complications, you have quite of the vitrectomy. I mean by that, you have quite a lot of complications. And in your hands, of course, complications are small, but that you cannot extrapolate to all of surgeons. And that is a little bit, even in the YAG laser, we have heard also, you have those who are very familiar by doing YAG laser, others who are less familiar, and also there you have complications. But I would like to open this presentation to the questions of the panel. Maybe John, you do the total vitrectomy, I think. Yeah?
I prefer to do floaterectomy when it's possible, but I had a question for Jerry. In the young patient without PVD who has a visible vitreoschisis of the posterior cortex, who is very bothered, you can see them with the OCT with swept source, but when you look at the fundus, you can't see what's bothering them, and they're very bothered. What is your approach for this type of patient who can be often depressed and psychologically quite upset by it?
Well, the experience that I've had over the last 10 or so years is shifting. I was very careful initially and then increased my activity by lowering my threshold for accepting to-do patients, such as the one that you described. But I now find myself slipping back to a more conservative approach in people in their 20s, because in spite of the data that I just presented, I have no data on 25 years down the road. And I can't sit there and tell them what will happen in 25 years. And I think it's important that we be honest about this and share that with individuals. But more specifically, the study that I alluded to and what I think you're referring to in between the lines is the phenomenon of recurrent floaters. If you do a limited vitrectomy in an individual who does not have a PVD, there's a chance that they'll develop a PVD. So we recently looked at our data set and we identified that that does occur in 4.9% of cases. A subgroup analysis actually shows that the real risk of a new onset PVD in someone that you did not induce a surgical PVD is about 15%. And we have further identified that the high-risk individuals are young, myopic males. 95% of the people in whom a new onset PVD created recurrent floaters were young, myopic males. And so my approach today to a young myopic male would be to discuss at great length the fact that to avoid that 15% risk of new onset PVD and recurrent floaters, we would need to induce a surgical PVD. And that does come with risks of iatrogenic retinal breaks, which, if identified in the OR, can be treated then and there. But there is a chance that will occur postoperatively. So 85% chance of no new onset PVD and recurrent floaters is pretty darn good, but it does change my approach as I just described, and will influence the way we speak to patients moving forward.
Mm-hmm.
In the specific,
Yeah.
sorry, just on the same topic, in the specific case, if the patient does present a post-op PVD, will he propose repeat vitrectomy if the patient asks for it and
yes,
is willing to take the risk?
The cohort, there were 14 patients who experienced recurrent central floaters due to new onset PVD. Only 11 of those 14 requested reoperation, which was performed without complications, and they were extremely happy. And we showed that their vitreous echodensity after the new onset PVD increased, their contrast sensitivity decreased, and then after the second vitrectomy, everything was normalized once again, and they're all doing very well.
Yeah, there is a question from the audience asking that to try to avoid posterior cataract formation, you can do the partial vitrectomy. That is of course correct. But is there another approach in order to avoid cataract surgery? I don't think that up till now we can avoid it. But what I think it is quite interesting is that when you leave a part of the anterior vitreous, we now know more about the anterior hyaloid and the anterior interface, and that the anterior hyaloid will also detach and cause an AVD with time, and starts typically as well around 40-45 years. And if you look at the patients older than 60, approximately 70% of them have an AVD. So I think that also AVD is much less visual disturbing than PVD, for sure. But the vitreous, the anterior vitreous, will not detach because you have the vitreous base that is so tightly attached, and then you still will have some deposits of debris or whatever that will float in that remaining anterior vitreous. So I don't know what will give the future of that.
Well, what we learned from the experience of leaving anterior vitreous is that it does not contribute to vision degrading myodysopsia as much as the central and posterior vitreous. We have not observed AVD, but in life you see what you seek. And so maybe we need to look at that more carefully.
Yeah, I think also. Well, it is quite interesting, a very good discussion. I don't know whether, yes, please, Kentaro,
Yes,
you have
I have a question.
Yeah.
Thank you for a very informative lecture. I'm curious about, my question is similar to what John just said. A very young patient without posterior vitreous detachment and complaint of a very, very strong floater symptom. And did you ever do you have any data for those young patients in age around 20 years without posterior vitreous detachment? Did you measure any contrast sensitivity, or did you have any vitreous aggregation, or measured by ultrasound B mode? Does that data show the objective difference?
Yes. I see a lot of people in their 20s, and only those individuals who have degradation in contrast sensitivity as well as increased density by quantitative ultrasound are candidates for surgery. I never operate on anybody who has a disconnect in the workup. And so there are people who are, as you described, and as I mentioned earlier, 8 years ago, I had a lower threshold to operate on. I was very conservative. 5 years ago, I had a lower threshold, but beginning, I'd say 3 years ago, my threshold is changing because of what I described earlier. So yes, we have measured their vitreous density. We have measured their contrast sensitivity. In many people, they're not abnormal. And I see in their faces sadness. Their faces drop when I tell them that they're not candidates for surgery, because they all come hoping for the cure. I want to be perfect tomorrow. But I'm able to turn that around by telling them, listen, I'm telling you good news. You shouldn't be sad about this, because compared to hundreds of other people, your vitreous is not dense enough and your contrast sensitivity is too good to require surgery. So this is a very useful clinical approach to patient care, because both people that you find meet the criteria will undergo surgery legitimately because of what we found, but also people that we say no to will have an understanding as to why, as opposed to feeling like, why don't you like me? Why would you operate on that person and not me? Is there something about me? And in the absence of objective quantitative metrics, we're reduced to doing personality profiles for which we're not really trained, and we shouldn't be in that position. And that's the clinical care aspects of how to use quantitative objective indices that evaluate the patient's status.
I completely agree with you. I completely agree with you. So sometimes I refer my patient around like 20 years old to a psychiatrist if I don't see any objective vitreous opacity in it. I perform every objective examination and find when I cannot find any objective evidence of his or her symptom, I sometimes consider referring to the psychiatrist.
Yeah, there's no question that there's a personality profile to the patients in this category. Clearly, these are perfectionists. These tend to be engineers, people who demand a lot of life, and there's nothing wrong with that, is the point that I'm trying to make, as long as we have numbers that corroborate their subjective experience. I tend not to refer patients to psychiatrists because I don't want them to be insulted by that judgment, which I think might happen. It's a delicate subject.
It might, yes, it's very delicate, yes. Of course, I'm careful about that, but
of course, yeah,
of course. But when the patient's is so, wanting to cure something, yeah, sometimes I refer.
We have a question also from a colleague who asked, what are the indications of complete for full vitrectomy, and what type of postoperative complications have you observed? I think that, yeah, this is a general question, but maybe the first part of this question, what are then the indications of full vitrectomy?
Well, I think as I sit here today, young myopic males who do not have a PVD, I will discuss with them extensively the data that I just presented to you, which we're writing up and will be published soon, and offer them the options. I predict that they'll say, you know what, I'm going to take my chances, because if there's only a 15% chance that I'll get a new onset PVD and a recurrence of my central floaters, I'm going to take those chances, because I'd rather deal with that then than have to deal with the risk of a tear of the retina during a surgical PVD, which studies in Korea showed were on the order of 30%. So I think that once those numbers are shared with the patient, the majority will probably choose not to have a PVD induced. But I know that the rest of the world doesn't approach it the way I've described. And I know that it's common practice to induce a surgical PVD and take out as much vitreous as possible. But Steve Charles once told me that vitreous is not cancer. You don't have to take all of it out. And you just have to treat the problem, whatever that might be. So I ascribe to that school of thought.
Yeah. So we can continue to tomorrow if we want, because there is, of course, many things to do. But thank you very much, Jerry, for your time, and also for all the other speakers, of course. We have now to proceed with the last speaker of today, and this is a completely different topic. This is the topic of the visual snow syndrome that is often confused with floaters by quite a lot of patients. And I think it is important that we have now the expert, the person who described that first, which is Christoph Schankin, who will explain us more about that entity. Thank you for coming as well.
Thank you, Professor Tassignon, for the kind introduction and for the invitation. My name is Christoph Schankin. I'm at the headache clinic in Bern in Switzerland. And I'm basically working with headache patients, but I also work with patients who have visual snow syndrome. And they might primarily complain of floaters. So I have some patients who come for floaters, and then we find out they have visual snow syndrome. And it is nothing that comes from the eyes, in my opinion. It's something that comes from the brain. And I wonder, indeed, if you also have patients like this in your clinic and what you do with them, and if we could help them together when they have both visual snow and floaters. So I would like to start with a little case that has been published more than 10 years ago, and it is very instructive since it's a case of a young girl. She's 12 now, and she used to be really normal, no medical problems except for some migraine with aura. Typical migraine once or twice a month, nothing severe. And then at age 10, from one day to another, her vision changed completely, and it was not a migraine aura that she experienced around that time. And she's a girl, and she knows exactly how to draw, and that's what she drew. So she was able to draw her vision. We have heard that before when patients draw their floaters, and she also drew her floaters, and they are here. She depicts them here. So she calls them squiggles and lines, and she can see them everywhere. She only draws them here because if she did draw them everywhere she saw them, she would not have any space to draw the rest. So this is one of her symptoms. That started from one day to another and stayed there for 2 years and didn't go away. Another symptom are palinopsia. So these are after images. For example, when she looks at a house and she looks away, then it stays in her vision. Same thing with a tree here. And when she looks at the blue sky, she sees lots of floaters. And she also sees tiny points that are shooting around. We all can see them. It's the Scherer phenomenon or blue field entoptic phenomenon. And we can see 2 or 3. And these patients, they see hundreds of those, thousands of those every time they look at the blue sky. And here in front of the tree, she also sees other things. And this is interesting what she writes when she looks at dark surfaces like the tree or here on the house. She sees white points, white dots flickering around. And when she looks at higher, brighter surfaces, she sees colors or darker spots. And these are flickering around. They are like going on and off all the time. And actually for her, these are the worst symptoms. The floaters, they are less severe, but these things, this flickering, it's present all the time, 24 hours a day with eyes open, eyes closed, and it's like driving her crazy. Now, we once tried to visualize this. This is a normal picture, and this is like the tiny dots in front of the dark. You see brighter dots in front of the bright areas. You see darker dots, and they are flickering around all the time, like going on and off and from gray to white. And this resembles a bit the view of a badly tuned analog television, like this. And this is English, the TV snow. And the patients, when they come and see us, they say, I have the vision as if I had TV snow in front of my eyes all the time. So this is the key symptom of what we call visual snow syndrome. And if you don't have this, you don't have visual snow syndrome. That's one of the take-home messages probably from today. Now we've been able to characterize these patients at Extenso several years ago. We were talking to more than 100 patients and phenotyping their clinical problem. We are neurologists and we are good at phenotyping. And we found of those 120 patients, 78 did not have any other eye problems. So they did not have eye pathology except for visual acuity question with refraction, but everything else was totally fine. And we found out that actually from those 78 patients who all complained of persistent visual snow, of those 78 patients, 92% had at least 3 additional visual symptoms from the same group as this young patient we talked about previously. So they had palinopsia, they had enhanced entoptic phenomena, so they had lots of floaters, they had blue field entoptic phenomenon in an extensive way, and they all were photophobic and they had impaired night vision. So when you, those is the way they see their palinopsia. They look at the tree in front of the nice Californian blue sky, they look away and they still see this tree next to it. They have other kinds of palinopsia like the trailing, and they have floaters like this. And this probably resembles what most of your patients complain of when they complain of their floaters. So really obscured vision. We defined those symptom agglomeration as a syndrome, and we called it visual snow syndrome. And we said it must have the visual snow as primary symptom, and then at least 2 of the following additional symptoms. And we were sure it was not migraine visual aura. And importantly, the eye doctor had to say that this is nothing he would say that comes from the eyes. How often is this? How frequent is this? There's one study from the UK where they actually did a crowdsourcing study, about 1,000 lay people, and they applied the visual snow syndrome symptoms on those subjects. And they found out that actually 3.7% of those 1,000 patients, they had the visual snow, and several also had additional symptoms, so that the criteria for the syndrome are fulfilled by about 2% of the population, which is quite high, I must say. It's much more than I had expected, but it's interesting. Probably most of these subjects, they see that without knowing that other people see differently. So they have this their entire life. How is the dynamics of this condition? So as I said, there is a group of subjects who have that since childhood, and in our population of the 78 subjects, it was 24%. They had known this visual snow since childhood, and in the remaining, it started around the age of 22, and it was continuous, so it didn't go away. Over several years, over more than 8 years, it stayed like it was, and it was constant in 40%. It was progressive worsening in another 40%, and it was stepwise worsening. So that means that one symptom comes after the other in about 13%. So it can be a progressive neurological disease. but it also can be something that just stays constant from the beginning. Importantly, it has to be said that all exams in these patients are normal. So the eye exam is normal, the MRI is normal, the neurological exam is normal, and the lumbar puncture, EEG, etc. They are all normal from examination. We investigated the natural cause of that condition by recontacting this group of 78 subjects about 8 years later, and we found that the visual snow is still continuously present in all 100% patients we could reach. Initially, there was a group of patients who did not meet the criteria for the syndrome, and over the years they developed additional visual symptoms, and so they finally met the criteria for the syndrome. And here one very interesting thing, and that might overlap with your work also, is we asked about the most bothersome symptom. And as I said in the beginning, in this young girl, the visual snow, that was what bothers her the most, because it was always there, with eyes opened, with eyes closed, at every surface they looked at. So most patients said the worst symptom for me, that is visual snow. And this, the suffering from the visual snow alone, that reduced over the 8 years. But what increased finally, that were the entoptic phenomena. So that were the floaters. It's their low numbers, I must admit, but I think the floaters and these symptoms, they because they are not continuously present, you do not adapt as easily to the floaters as you might adapt to the noise in the view. This is a debilitating condition because symptoms are always there, with eyes open, eyes closed. Patients suffer from the additional symptoms such as the palinopsia. So you try to read, this is German, they try to read something and they cannot, because when you read one word and you want to read the next one, you see the first word over the second, and it makes it much more difficult for you to read. Patients have impaired night vision that's preventing them from driving or from performing at night. I have not talked about the non-visual symptoms they have. They have tinnitus in about 60% of subjects, and because they have this input all the time, they have concentration difficulties, irritability, and tiredness, and so on. And patients also suffer from being diagnosed as psychogenic or malingerers. So they because the exams are normal, the eye doctor, the neurologist, and finally also the family physician, they say, well, you're stressed and it might be a consequence of stress and you should relax and all will be well. I give you an antidepressant and you'll be fine. So that's very suffering. That's really, really bad for the patients. There's a very high comorbidity with migraine. About 60% have migraine, and typical migraine aura is also higher than we would expect from the general population. And we see when you have migraine, in addition to visual snow, then you have a much higher chance of having additional visual symptoms here. So that means that when you have both visual snow plus migraine, you have a more severe phenotype of visual snow syndrome, which is not the case when you have migraine aura compared to the non-migraine aura. The syndrome is equally severe, but probably we think that this might mean that there's one underlying a common pathology behind the visual snow and the migraine aura. We were looking for the lesion, where is the problem in these patients, and we were doing PET scans and MRI in a group of migraine patients and a group of visual snow patients and a group of controls. Here we were comparing 20 patients with 20 controls, and we were looking at metabolism and at the same time also at the gray matter volume, and we found that there's a hypermetabolism in the lingual gyrus on the right side, and at the same area there is a hypertrophy in the adjacent fusiform gyrus, also on the right side. So we have a congruent metabolic and structural change in this area that truly demonstrates this might be a very important brain region for the generation of the syndrome. And it's the first demonstration that this is really something that is also involving structural and functional changes in the brain in patients that have been over decades labeled as malingerers. And we then were looking at what happens with the visual evoked potentials in these patients, and we see that the late phase of the VEP is coming even later in patients compared to migrainous and controls, and then supports that this area, the lingual gyrus, that is the visual association cortex, that is also, when you measure it electrophysiologically, it's also altered in patients compared to controls. And when we look at what happens in the brain when you're trying to see, the image is starting in the retina and then in the thalamus. It will be transferred to the cortex, to V1, V2, and other areas, and finally we understand and we realize what we see. And in between, there's a lot happening. And we look at the lingual gyrus and the fusiform gyrus. It would be in this area, and we might think that parts of the syndrome, they are generated in the V3 area of the brain. Now we found other differences between patients and controls. We had some hypometabolism here in the inferior lobule of the parietal area of the brain. This is an area, when you have a stroke here, you develop polynopsia. So probably we do have a correlate of the polynopsia in our patients. And we also found hypometabolism in other areas, in the inferior parietal lobule, in the superior temporal gyrus, which are areas that are associated with hearing. It might be a correlate of tinnitus. And we have changes in limbic and temporal structures, which are probably reflecting symptoms such as concentration problems, irritability, and tiredness. So what does that mean? So there are many other studies that have been done by us and by other groups that were really trying to understand the syndrome. When we step back a bit and try to see it from a helicopter view and try to integrate what actually means migraine in these patients, we first have to understand what is actually migraine. And for migraine, we now have the impression that migraine is a disorder of sensory processing. So it actually is answering the question, why don't we always feel head pain? Because we have the meninges, we have blood vessels in there. They are densely innervated by the trigeminal nerve. The trigeminal nerve, it goes into the brainstem. And here in the brainstem, there is a connection in the trigeminal cervical complex that then moves up. That's not shown here in this picture, but it moves up to the thalamus. And then it's another connection, and then it goes up to the cortex, and in this area you realize head pain. So why isn't this route here always on? Well, we think it is not on because we have areas in the brain such as the hypothalamus, PAG, the dorsal pons, which have a suppressive effect on the transmission between this neuron and the second order neuron. And that's preventing us from having head pain all the time. And we have data from neuroimaging that in the earliest phase of the migraine attack. In the premonitory phase, these areas, they are dysfunctional and they break down, and then they let the information from the meninges, they let them go into the higher orders, where we then realize head pain. And that means we have meninges, we have information from the ears, we have information from the eyes and from the gastrointestinal system, which are blocked. Those information, they are blocked by this fence here, by this filter from getting into the brain. And during the migraine attack, this filter is broken, right? It's temporarily broken, and we realize headache, photosensitivity, photo and phonosensitivity, and nausea and these symptoms. So migraine is a disorder of sensory processing. In visual snow syndrome, we probably have the same, but we have that thing all the time. Let me explain what I mean with this. So we have visual snow, that is the noise within the optic system. Is that probably just this? Is this the retina that is active all the time? We know this from our smartphones. When we try to take pictures at night, they are always noisy. When the sensitivity is high, there's a lot of noise. Is that something that's happening all the time in the retina? What about the entoptic phenomena? We see parts of the optic system. We have heard a lot about floaters today. So the aggregations and the opacities in the vitreous corpus that cast a shadow on the retina, the blue field entoptic phenomena. Here it should be the white blood cells in the retinal vessels. They cast a shadow on the retina photoreceptors, and then there's light coming into the eyes, and why isn't it all the time too bright or not enough bright? Because there's probably a system in the brain that's modulating how we perceive light sensitivity. And why don't we see the noise in the retina? Why don't we see the entoptic parts, the entoptic phenomena all the time? Because there is maybe a system in the brain that is filtering this information out of and preventing us from seeing this all the time. So maybe we have normal visual input in visual snow syndrome that is impaired in processing when you have the condition. So we would say, nobody would like that I draw things on this nice paper here. But the pathophysiology of visual snow syndrome is that probably a disorder of visual processing. So it might here overlap with those areas and with the pathophysiology of migraine in this condition, mainly in the visual parts, but we also have tinnitus. So it's also affecting other parts of our sensory processing. So what can we do? That's the bad and the brief answer. We can do nothing. We have once done a review here, and here was published data by 2017, and we actually see that there was no response to most medications. And then finally, we have looked at more than 1,000 patients, and we were asking them, what groups of medications have you tried in the past? So there's a lot of things: antidepressant, recreational drugs, it's quite high, vitamins, anti-epileptics, other medications. And we have asked the patients, did those medications, did they have a positive effect? That would be the magenta color here. Did it have a worsening effect? That's green. Or did it have no effect at all? That's the blue part. And we can see that actually most substances, you have a risk to worsen the patient, which is higher than the chance of improving the patients. Except for the vitamins here or the anti-epileptic drugs, or the benzodiazepines, but we have several patients who tried the benzodiazepines. They got dependent and they increased their dose. They had all the side effects. And then when they tried to reduce the visual snow, they tried to reduce the medication, the visual snow got worse and even worse than it was before. And so I would definitely not recommend to do these kinds of drugs in the patients. We sometimes try anti-epileptics or the vitamins, but we are more interested in doing neuromodulation in these patients, because that, I think, might be a better way forward, because the pharmacological approaches, they're just not very promising. All right, so that was a brief overview. Just to summarize the visual snow syndrome, that is visual snow, the main symptom plus additional visual symptoms. That means floaters and others. There are additional non-visual, perceptual and non-perceptual symptoms, such as the tinnitus and the concentration problems. It is not psychogenic, it is not migraine aura, but it might more be a dysfunction of visual supplementary cortex, or even more like a network disorder that then involves mainly the visual association cortex. I would like to thank you for your attention, and I'm happy to discuss this with you, maybe also discuss some patients. I even had once a patient who had vitrectomy for the floaters and then later developed visual snow syndrome. So maybe he already had the visual snow and was done surgery on that. The floaters were better, but the visual snow was even worse afterwards. So happy to talk about this, and thank you for your attention.
Thank you. Thank you. Very interesting. Well, the reason that I wanted to have you here as well is that we do have indeed patients who, more and more patients, society even, are including the visual snow syndrome because they consider it's just alike than the floaters. And I think that it is wrong. But on the other hand, we have to, as medical doctors, we have to be able to separate the visual snow syndrome from the traditional floater patients. And we are mainly dealing with patients who are around the 20, 22, 25. And those are the patients that are coming to our clinic badly complaining about floaters, where we don't see anything in the vitreous body. And then we are puzzled. And that's the reason why I wanted to do that. We are also doing that, and then looking at the face and 145. And well, we don't find them often, certainly not, but from time to time we do. Of course, it's a small number of patients that we have examined, but I do like to ask as well, to include as well the VEPs in order to see in those patients whether we find something, we can objectify something. Okay, this presentation is of course also open for discussion. There is one person attending this meeting saying, I have indeed floaters and visual snow syndrome. Is that floaters? Is that not? Well, everything is a little bit difficult. We cannot tell that because we haven't examined the patients, but I think that you answered quite a lot of his questions. Are there other questions from the panel here?
Just a comment. I thank you for this brilliant presentation. I, as an ophthalmologist, have been recently, where I was about 6 years ago, the visual snow syndrome, when a young patient, 22 years old, came and saw me. That was a patient that told me about it. Then I started reading about it. And since then, I've seen about 10 or so. You said it's not psychogenic. Are there ever found any triggering events in these patients, or did it disappear spontaneously from one day to the next?
So we have both. We have patients who have triggering events. Some have migraine aura before it starts. Others, they are always in a stressful situation. So I don't know if that's like the can be increase the vulnerability to develop something in a predisposed patient. Other events, trauma, head trauma can be something. Here we also know that it can disrupt the network function of the brain. So there are some patients, but we also have patients who say everything was fine. It just from one day to another, I was lying on my back and was looking at the sky, and suddenly, boom, there they were. All right. We also have drugs. We have drug patients. They have another diagnosis. So that's hallucinogenic persistent perceptual disorder, HPPD. They can manifest with the same syndrome, actually, but we would not put them in the same box just because they complain of the same symptoms.
I've seen a few.
In your follow-up study, where there was an increased number of people complaining of floaters several years after you initially saw them, is it your impression that this is because of increased awareness or paying more attention to their vision, or did they have an event such as a posterior vitreous detachment?
That is a very good question. I don't know. They have not. They have been to doctors. We have asked them if they had new diagnosis from that. They have neglected that. So no. As far as we know, no new eye pathology. But my impression was that the floaters were similar as before, but for them the perception was just worse because they did not adapt. Because the floaters, they float around, right, and they are always different, and you cannot adapt to that syndrome.
Okay. Okay, well, I think this was a very exciting session, and thank you very much to all the speakers for their contribution. And I'm sure that this is not the end, and that we have to continue on this kind of work. And with some of you, we will meet each other anyway in the near future. Thank you again. And I would say have a good rest, have a good day, and have a good afternoon for the Europeans. Bye-bye.
Thank you very much. Bye.
Thank you.
Bye.
Bye.
Thank you, everyone. Bye-bye.
Bye.
Thank you. Thank you. Bye-bye.